Hereditary spherocytosis is usually inherited as an autosomal dominant condition. The most common defect is on chromosome 8. Hereditary spherocytosis results from genetic alteration of one of 5 genes that encode for the red blood cell membrane proteins, and this leads to the characteristic shape of the spherocytes. The change affects the lifespan of the red cells, as the spherocytes are more prone to hemolysis. Splenectomy virtually eliminates hemolysis and anemia in moderate to severe cases. Presentation occurs at variable age, and it may be asymptomatic for many years. Most have a mild to moderate hemolysis. The anemia may worsen with severe infections and with infectious mononucleosis, which temporarily increases the spleen size. The anemia may be more pronounced in pregnancy. Clinical signs include jaundice, reduced pallor from anemia, leg ulceration, and tenderness in the right upper quadrant from gallstones. The top 3 differentials for isolated splenomegaly are CML, myelofibrosis, and malaria. Complications of hereditary spherocytosis include pigment gallstones, which are common in hereditary spherocytosis, and the right upper quadrant may be a presenting problem, leading to the diagnosis. Half of affected adults have gallstones, particularly when the hemolysis is severe. Relevant investigations include a full blood count and blood film, with the typical appearance of spherocytes and hemolysis. The LDH, unconjugated bilirubin and reticulocyte levels will be high, and the haptoglobin decreased or absent. Coombs would typically be performed to exclude the diagnosis of an immune-mediated hemolysis. More specific tests for hereditary spherocytosis include EMI binding, which is an eosin-based fluorescent dye that binds red cell membrane proteins. The mean fluorescence is lower with hereditary spherocytosis, detected using flow cytometry. If EMA binding is not available, then the osmotic fragility test is useful, although the sensitivity and specificity are low. This test measures the erythrocyte resistance to hemolysis while being exposed to varying levels of a dilution of a saline solution. Treatment of spherocytosis is aimed to minimize the hemolysis. No therapy is available to target the faulty membrane protein. Folic acid supplementation is important, as the requirement is increased with the increased red cell production. This is particularly important in pregnancy. With severe cases, a combined splenectomy and cholecystectomy is not uncommon. Such patients would require vaccinations for encapsulated organisms.